The headline of the findings from the study that we conducted, which basically wanted to assess the safety and efficacy of DCB versus bare metal stent in femoropopliteal lesions that are amenable to both treatments, meaning that you can either go with the angioplasty or with a stent. And we showed in this analysis that DCBs were superior for the primary efficacy of 12 months by duplex ultrasound using peak systolic velocity of 2.4. And they were also superior when we looked at the primary efficacy of clinically driven TLR at 3 years. There were no differences in mortality. DCBs had a lower major adverse event, which was mainly driven by lower clinically driven TLR at 3 years. As a scientist and as someone that has been involved with these trials, I've been a little bit frustrated, to be honest with you, because we have had a number of randomized clinical trials showing the superiority of DCB versus angioplasty. And as you know, there is still about 20 to 30% of patients in the United States that are receiving angioplasty instead of DCB. There is another 30% of patients that receive stents. And the question has always been for me clinically, at the level of the patient, what should I do? Do I go with a stent or do I go with DCB, given that we don't have no randomized trials that have compared DCB to bare metal stent? So the whole idea was initiated from a clinical need. What do I do with a patient that has a femoropopliteal lesion that is amenable to both stenting and DCB? And what should I do? Do I have any data to back this up, my approach? And we found out in this study that DCB was clearly superior, both in short-term and mid-term, long-term, 3 years, compared to bare metal stent. As a scientist and as someone that has been a participant in these clinical trials, as you know, there are multiple randomized clinical trials showing the superiority of DCB to angioplasty. But despite the data, about 20 to 30% of patients currently in the United States are receiving angioplasty instead of DCB. So there's obviously an opportunity there. There's also an opportunity because 30% of patients are getting bare metal stents. And the question has always been for me that when you have equipoise, when you have a lesion that is amenable to both, which approach should you take? We don't have any randomized data. So we wanted to use prospectively collected data, core lab adjudicated, use sophisticated statistical methods to be able to get a comparative group of DCB versus stent and show which one is more efficacious and safe. And we found out that DCB, impact DCB, was superior both in short-term, 12 months, and mid to long-term, 3 years, compared to bare metal stents for these lesions. I was a little bit surprised with the long-term data. I felt that maybe in short-term, obviously, maybe, there would be some superiority with the DCB. But when I saw that in long-term, they really hold and they're able to prevent neointimal hyperplasia, and they can persistently keep that patency open and give us a lower clinically driven TLR, that gave me reassurance that for lesions that are at equipoise, I can take a DCB route. And we know that the stents, while they're wonderful for acute luminal gain, they really have a lot of challenges in the mid to long term, especially once you have stent occlusion. Technically, it's much more challenging to cross these stents. And then obviously the cost associated with treating an in-stent restenosis or occlusion is much higher than treating a native stenosis or occlusion. I think that obviously the questions that come up are twofold. One is that, well, what do DCBs look like against DES? And I have already reached out to those companies that do offer both of those modalities to see if we can do similar analysis. Because at the end of the day, Jocelyn, is about the patient. We need to have this information to make educated decision about what treatment we're going to offer the patients. The other question is obviously the efficacy and safety of DCB versus more advanced scaffolds, like, let's say interwoven stents. And how do these DCB balloons do with those kind of stents? And I'd be interested, hopefully in the near future, to be continuing those questions and ask these appropriate questions to be able to support interventionalists, surgeons, folks that treat patients, so they have that data and they can make their decisions with some evidence rather than just guessing as to what treatment is best for the patients. We're very excited. I think the highlight of this study was that drug-coated balloons are superior in short-term, 12 months, assessed by duplex ultrasound with a peak systolic velocity of 2.4, and in mid to long-term, 3 years, have a superior result with the endpoint of clinically driven TLR compared to bare metal stents in femoropopliteal lesions that are amenable to both treatments. These are patients with Rutherford class 2, 3, and 4.